So thank you very much, everybody, for joining the next edition of Oncology Beyond the Obvious. Today, we are taking a closer look at adjuvant nivolumab in high-risk muscle-invasive urothelial carcinomas, the expanded efficacy from CheckMate 274. And we have a galaxy of speakers and the moderator, so I will not get between the two of you. My job is to introduce Dr. Amish Vora, who is going to interview, and Dr. Vora is the founder and chief officer of Hope Oncocare Clinic in New Delhi. He has been, raising this bouquet with excellent services for all the niche patients with oncology in the National Capital Region. And recently conducted a Hope Oncocon conference, which was an immense success with more than 5,500 people attending it. So without wasting much time, may I
Ramesh,
hand over
ऑडियो
to my
काम नहीं कर रहा लैपटॉप का
co-program director, Dr. Amish Vora,
बार बार ही आ रहा है
to
चेक
start the
माई ऑडियो
proceedings.
डिवाइस चेक फेल टू डिटेक्ट
Amish, Ajay, thank you. So Amish, over to you. Please carry on.
Thank you, sir. And can I have my first slide, please? So as we customary go, before we start the interview, normally we like to present 7-8 slides about what are we going to discuss today. And after that, we will start our session with Dr. Amit. So today's topic is adjuvant nivolumab in bladder cancer. Adjuvant itself means that patients who have resected or undergone surgery. Next slide, please. So the paper which we are going to discuss today is an expanded efficacy from CheckMate 274. Now, the first paper of CheckMate 274 was published in New England Journal of Medicine. And now we have an expanded efficacy, that is the expanded follow-up. And Dr. Matthew Galsky, if you see the YouTube, he has got many videos. If you see about the CheckMate 274, you'll realize that he's so passionate about this particular topic. So it's in high-risk muscle-invasive urothelial carcinoma. Next slide, please. When we say high risk, it was defined as PT3 or PT4A or node positive if no neoadjuvant chemotherapy was given. And if the neoadjuvant chemotherapy was given, that is the platinum-based chemotherapy or any chemotherapy, it has to be YPT2, YPT4A, either of any of these subgroup with node positive. Bladder cancer and upper urothelial cancer patients were also included. That is cancer of renal pelvis and the ureter. Next slide, please. So the randomization was 1:1, but it had to be done within 120 days of surgery. And patient has to have a disease-free status for at least 4 weeks. There were 709 patients who were randomized between the placebo and injection nivolumab 240 mg every 2 weeks for 1 year. Maximum 1 year, 1 year or less than 1 year, depending on whether patient could tolerate or stop for any other reason. Next slide, please. The primary endpoint was disease-free survival, and the secondary endpoints were OS and NUTRFS, and this is basically a new terminology. Even in breast, we see that. So non-urothelial recurrence is basically what they wanted to see, the free survival. And there were two groups in this, ITT, that is intention to treat, and PDL1 more than or equal to 1%. The median follow-up at the time of publication was 36.1 months. Next slide, please. So this was the primary and the secondary endpoint for ITT. If you see the strict primary endpoint, that is DFS, this was 22 months versus 10 months. 22 months was for patients who received nivolumab and 10 months for the patient who did not receive nivolumab. And OS and the other primary endpoints, you can see the curve separating. Next slide, please. This was PFS2, again, a new concept which has started in oncology. The idea of PFS2, what I have understood, is that If you give nivolumab in the first line, or if you give, say, experimental arm in the second line, but if you have given in the first line, and if it is actually beneficial beyond the first line, then your PFS2 also should be statistically significant. Next slide, please. This was something surprising results, good for the patients, PD-L1 positive patients, and we have PD-L1 positive patients, around 40% of the patients who were PD-L1 positive, and around 60% of the patients in this arm who were not PD-L1 positive. So they took out the subgroup of PD-L1 positive patients, and what they found was the median DFS was 52.6 months as compared to 8.4 months in the placebo arm. Now, this huge gap, this huge difference is, I don't remember last when we had seen in the bladder cancer. Next slide, please. What does the guidelines say? The guidelines say if you see following cystectomy, and this is the NCCN version 5 of 2024, following cystectomy, if patient has not received, the one which I had said, you can give adjuvant chemotherapy, cisplatin-based chemotherapy, and see in the bracket preferred, or consider adjuvant nivolumab. They have not mentioned about PD-L1 positive. They have not mentioned about category 1. In spite of 52 months versus 8 months, there is a DFS difference in the PD-L1 positive patients, and we will discuss about that later. Next slide, please. So now let's go to Dr. Amit Rauthan for many of the unanswered or the questions which need some detailed answers. Can we go to Dr. Amit Rauthan, please? We can close the PPT. Okay. Hi, Amit. Thank you so much for joining. And it is my customary thing, even though I requested you didn't send any of your CV. So I have tried to dig out something and tried to get. So Dr. Amit Rauthan is, Amit, I came to know that you have done your MBBS, MD from Municipality Hospital of NHL Ahmedabad. I didn't know that earlier. And you have done your DM in medical oncology from the Gujarat University. Amit, very few of the people are there from day one till now. In his career, he has stuck to only one hospital. Am I right, Amit? And that is Manipal Group of Hospitals in Bangalore. And that is something I have been seeing Amit since a long time. And, he is an ardent analyzer of the critical analyzer of the papers which get published. I remember he was one of the first one who started using immunotherapy on a regular basis. And I still remember that there was one RCC patient or a bladder patient, Amit used to say patient was on ventilator. And Amit said that we tried immunotherapy and the patient came out of ventilator. And at that time, this was the era when we used to start thinking, hum kab pehla immunotherapy hamare patient ko denge. And that is a time Amit probably had graduated. I think it is important to identify the right patients, and that's how what Amit sees. Amit also practices hematology apart from solid tumors, and I think in last 20 years he has taken part in clinical trials. He has given more than 500 plus lectures in the esteemed conferences, and he has got many publications to his name. Thank you so much, Amit, for joining us.
Thank you, Amish. First of all, thank you very much for having me here. It's really a pleasure to be part of your meeting. It's a wonderful format. It's a very different format from all the other meetings we have attended, and I actually enjoy listening to your analysis and the way you interview, and then the session which happens as a debate in which people start telling their opinions. So it's a very nice format, and it's really, thank you for having me here.
Thank you so much, Amit, for being there. So, Amit, let us start question answers. If you are ready, we have 25 minutes to this thing. So, first 3 to 4 questions, Amit, yes or no, or very short answers, and then we'll go into the details of that. PT3, PT4, N or node positive. How many patients in your practice are cured by surgery alone?
Very few. Surgery alone is very few.
20%, 30%, 40%, 50%?
Surgery alone will fall below 20%.
Will fall below 20% in this high-risk muscle-invasive cancers. Perfect. Neoadjuvant chemotherapy, which we give to almost every patient who comes to us, medical oncologists, for opinion. How many of these percentage of patients have YPT2, YPT4A? Because, if you read the literature, around 50 to 60% patients have near complete response after neoadjuvant cisplatin-based chemotherapy. And that's how it became a category 1 recommendation, right?
Right. Right. Difficult to give a very short answer here. It's basically depending on how you saw the patient initially before when you were referred for neoadjuvant chemotherapy. So if you actually got those early invasive disease with no extension, no nodal involvement, and then you did neoadjuvant, those patients are definitely responding well. And we have seen our own group of patients where we've actually achieved 60, 70% PAT CRs. But
Wow.
we have come with T4 disease to start with. Those patients, we have definitely seen they don't get into PAT CRs very easily.
They don't get into the PAT CR. Perfect. Now, little different. We have now the extended follow-up data of POUT study in 2024. And the 5-year DFS shows that there is a 62% versus 45% when the
Right.
patients of upper urothelial tract cancer were given adjuvant chemotherapy. Tarini Sahu's very favorite restricted mean survival also was improved by 18 months compared to 10 days and 15 days and 20 days of many of this. And 5-year OS also was significantly higher. Do you routinely give adjuvant chemotherapy to these patients?
Yes, POUT is practice changing. Absolutely. We did not have anything for upper urinary tract, and it was such a difficult trial to do, but clearly showing a huge DFS benefit. Even the OS benefit is significant, though if you see the upper boundary, it's exactly at 1. But clearly it is significant. So I think upper tract, there is no controversy. We are offering our patients chemotherapy. And the good thing about POUT is if your patients are not eligible for cisplatin, even carboplatin showed benefit. So that's the unique thing about POUT.
So how ethical, my idea of putting this question is it ethical to include these patients in a clinical trial if they could receive even carboplatin? Would your ethics committee allow today? Amit,
So-
I'm asking you
so-
this question.
So if you look at how POUT was done and when it was done, it was in a completely different time frame. POUT was a trial which took a long time to do, and it
No,
was a
today,
time back.
will
Yeah.
your ethics committee allow such patients to be included in clinical trial of any immunotherapy and not offering them even carboplatin? Forget about cisplatin eligibility.
दोनों आएगा.
Uh,
Yeah.
I think it's always a debate about carboplatin usage, and in a curative setting, we always want to use cisplatin. So in the present era, it's always about trying to explain why you are going to do carboplatin, for which patients, why would you want to choose it? But we clearly know our neoadjuvant and adjuvant data, at least for bladder cancer, we would not want to use carboplatin. Upper urinary tract, we still have the place for carboplatin. So
Still have the place for carboplatin. You didn't answer about ethical, but we will cover that later. Okay, so now my customary question. Do you think this CheckMate 274 expanded efficacy data published now is practice changing? Just yes or no right now.
yes.
Okay. Do you think the Niagara paper of perioperative durvalumab is practice changing?
Yes.
And do you think the adjuvant pembrolizumab, which is just published through 2 months back, same like CheckMate, do you think that is practice changing?
So a little
Right
less
now, yes or
emphatic,
no, Amit?
a little less emphatic, yes. A lighter yes.
Lighter, yes. Okay. If you have to put finger on any of these three, I think two, you have made it very clear. Between Niagara and between CheckMate 274, which one would you put above score? IMDb score like in Netflix series we see.
I think Niagara will now kind of trump the others because it just changes the setting we are in, It changes the way you would treat patients from the start. So that's why
Okay.
Niagara will probably be on top, and then with CheckMate, and then the
Then check, then things. Okay, perfect. So now we have to convince our urologists more and more to send us patients before operating upon. Okay, right. So let's come back to CheckMate 274, Amit. Do you think it was a well-conducted study? My specific points are inclusion criteria. There are two inclusion criteria. One is 40% of the patients received NACT. In fact, 40 to 43% patients received NACT. In today's age and world, including patients without NACT is something which I wanted to take your comment on. And second is there was a 20% patients of upper urothelial cancer.
right.
And imagine that these adjuvant chemo was not allowed in this study.
Right. So coming to all the 3 points individually, so I think absolutely yes, we should have more patients getting neoadjuvant chemotherapy because that's what we say is standard of care. So I think it's absolutely there. We would have liked to have a much larger population getting neoadjuvant chemo. But again, in practice, there will be varied reasons why patients may not get it. So at least it gets an option for those patients. So I feel that way, at least it's helping us in some ways.
Okay.
The second was we were talking of
Upper urothelial CA
yeah, this
inclusion.
point you did make this point. Practices have changed for upper urothelial, and having a 20% population did not make sense because it's not going to answer many questions, and even your statistical analysis for that 20% becomes very difficult. But I kind of think maybe the investigators that time were thinking if we got those some clear answer for them, we still can offer it to them. But really, it's a very small number, and I kind of think doesn't make sense having just 20% of patients of those.
700 odd patients, 20% is 140 patients, Amit. 140 patients can sway. If if you read the video of Dr. Vinay Prasad, in his video also he has said in the era of POUT, it doesn't make any sense to include 20% patients of upper urothelial CA for adjuvant nivolumab who were not offered adjuvant chemotherapy, and that also carboplatin. Now we have the data.
Right, absolutely. I fully agree with you. But the thought of for adjuvant chemo for the bladder component is a very controversial one. We have so much data saying that probably so the trials really did not pan out and they did not recruit enough patients. So we really don't have an answer for adjuvant chemo for patients who did not get chemo at all. We do that in clinical practice because of lack of options. But we have also found giving adjuvant chemo is difficult for most patients.
See, the accrual of adjuvant chemotherapy trials were difficult.
Right.
But if you see the meta-analysis of the 3 large randomized studies, even adjuvant chemotherapy, even in bladder cancer, it still increases survival, Amit. And if you see the NCCN guidelines, which I downloaded today, even today they say adjuvant chemotherapy is a preferred option, or you can give nivolumab.
Right. Though I would agree. That's the reason why we kind of give chemo in our minds to those patients. But agreeing fully that we have difficulty in giving adjuvant chemo. There's no doubt about that. It's been always very difficult, and a lot of GemCis regimes don't get followed clearly in adjuvant chemos.
So my next question is to you about the primary endpoint of DFS, Amit. We have discussed and debated this point in almost every OBTO where the DFS is primary endpoint. So I'm not going to ask you whether DFS is the right endpoint. What I want to ask you, in an adjuvant setting like bladder cancer, in a high-risk muscle-invasive bladder cancer, what delta of DFS, according to you, makes sense to change our practice? 5%, 6%, 10%, 20%? What delta?
So it's a very kind of a question which gets you into no real right answers there. I would kind of say a 10%
Give
delta.
your thought process.
So we at least we should have probably a 10% delta at time frames to say that this is really getting into a territory. But again, we keep saying in an adjuvant setting, if you should get OS somewhere there. With that delta, you need overall survival. If you're not getting OS, then you keep worrying, did this delta really give you the benefit?
So you don't think DFS of even 10% delta or 15% delta without OS data makes any sense?
It becomes so it is big. It's controversial. The reason is uh, when you make it as an endpoint, you kind of, so if you had an OS endpoint, then it makes sense because then you know everyone's getting treatment that way so that you can look at OS. Now, when you don't have that in a trial, you don't know what's happening post first line. And that creates a whole controversy of did that benefit or did the second line therapy make a change or
Correct.
the third line therapy make a change? We don't know even whether crossover was allowed. Most, of course, crossover was not allowed, but we don't know what percentage it's got immunotherapy in future. So that creates a lot of issues. I
Issues.
definitely say uh, OS is the gold and is the standard endpoint we'd want to, but there are some reasons where we would agree on DFS for those patients. Yeah, if it's a well-done clinical trial, like 274 is a well-done trial.
Absolutely. So 10% delta in bladder cancer versus 10% delta in ovarian cancer. I think the things change, but I will not go into the details. If you don't have an OS data, do you believe in PFS2? Nowadays, every trial gives PFS2.
It's an interesting endpoint. It's quite an interesting endpoint, and I think we are slowly, we are slowly kind of reading into it. But I don't think that's good enough an endpoint to say that's a surrogate for OS. I don't think so. We should do that.
I completely agree on that point, and thank you, because PFS2 is making waves in a very big way. Somewhere it doesn't make so much of sense. So let's come to results of 274, Amit. The ITT DFS was 22 months versus 10 months. And Dr. Sudeep Gupta always taught me that you should always see the placebo arm, how is it performing? So the placebo arm of 10 months, do you think is that the practice what we see? What it means is that 50% of your patients who are not given adjuvant chemotherapy, you already said that, but I just want to reiterate, will relapse before the 1 year.
Right. Uh, so I think this is real world practice. It does happen that way because if you look at most data sets in the comparator arm, we used to say within 2 years, most patients would relapse. At least 50% relapse in 2 years. Here it's happening within 1 year. That's the difference. The curves
Absolutely.
are dropping off quite faster, but it could be the patient risk could be more. So in a randomized trial, if your two arms are going this way, I kind of think we just need to, it will be depending on the type of patients you have included and the type of situation they are in.
No, but why I asked this question, if you remember, LEAP 002 in HCC has the highest DFS, 19.4 months. But the placebo arm, matlab the control arm was 19 months.
Right.
At the same time, you see the same control arm in the reflex trial, it is 14 months. And the sharp sorafenib is 10 months. So I
Right.
think the control arm or the placebo arm makes a huge difference.
Right. Absolutely.
Why I say this is because we will discuss, but Niagara study, where the EFS at 24 months have been reported, Amit, there even the median EFS has not been reached as yet. So what it means is that the median event-free survival is 59.8 months at 24 months. And here it is 10 months. Your
Uh,
comment.
So I would say so look at all the adjuvant trials of immunotherapy and look at all their comparator arms. You will see them ranging between 10 months to 16 months in all the trials.
Correct.
So if you look at it, the reality is that's how this group of patients is behaving. So if you look at Niagara, you have given everyone new adjuvant and you have given everyone new adjuvant plus in the non-comparator arm. So basically that's a different patient population happening in the sense your treatment is different. But if you look at the three adjuvant trials of Pembro, Atezo, and Nivo and compare their comparator arms, it ranges between, I agree with you, 9 months, 10 months is the least you got in this, but the highest you got was 16 months.
16 months. Absolutely right. In fact, the study was negative, basically.
Right. Correct.
And that is another dilemma in oncology, that we are slaves to data, and that the immunotherapy which gets the positive data ultimately enters into the guidelines. Let's come to the highlight of this study, PD-L1 positive, Amit. The DFS is 52 months versus 8 months. 52 months. Do you think, is it too good to be true? What are we dealing with? I have still not been able to. It's been 2 years since NEJM paper has that. I still don't know the answer to this.
No, it's good to see it. It's amazingly
Good
good.
to see.
It's
Absolutely.
amazing good to see it. So what we kind of can understand is there were only 43% of patients who were PD-L1 positive. Now this so one more thing about PD-L1. One thing we should not extrapolate between trials is the type of PD-L1 done. That's creating a lot of
Absolutely.
confusion.
Confusion.
So if you look at this trial, it is PD-L1 by 28-8 DACO, which we don't have. None of us have it and none of us do it. And they looked at
Correct.
TPS and
TPS.
TPS. So it's a very different PD-L1 positivity, which we don't know much about. And this group of patients definitely is doing very, very well in terms of DFS, in terms of even OS. You can see that though you don't hit statistical
Huge
significance, but you
differences.
clearly see a huge difference. A hazard of 0.52 for DFS in PD-L1 positive is really very significant. So I think clearly it is noteworthy. The issue happens because we compare this with the Pembro data. And in the Pembro data, we saw that PD-L1 positive and negative, there is an incremental benefit in both, but there's no difference really. And actually,
Correct.
the negative patients, the increment was more than the positive patients in the in our ambassador study. So that's where whole the controversy starts. But then understand, ambassador used 22C3, it looked at CPS, and that again is changing the way you're looking at PD-L1. So probably that's what's making a big difference also. So we should not be comparing these two PD-L1 populations because they may be actually looking at different populations.
You raised a very important point, Amit. Meta-analysis, the network meta-analysis and the standard meta-analysis in a metastatic urothelial cancer says that PD-L1 positivity does not make a difference. In Pembro study, PD-L1 made a difference, but not so much. And now suddenly what I'm hearing from you is because the 28-8 was used and because TPS was used, suddenly we had a different biology of the patients who behaved so well.
So my gut feeling is that big difference which you're seeing is probably choosing your patient better by doing that PD-L1. But again, are we looking at different populations is the issue. So look at CPS. When you're doing CPS, you're looking at tumor cells, you're looking at immune cells.
Immune
And
cells.
you are looking at that population. And here in 28-8 DACO, you are just doing the TPS and you are doing that population. Now, when someone does so dramatically well for this group of population, you start thinking, am I choosing in a different way? That's the only explanation for that bigger difference in positive patients and negative patients. But again, that's what instinct tells me. That's possibly the group patient population is getting chosen in a much better way. But again, we don't know. And I don't know how to put it in clinical practice because we won't be able to choose our 28-8 patients. We will not be able to do that kind of PD-L1 in our practice at all.
So Amit, understanding that what you are saying, is correct scientifically, NCCN guidelines still keeps Nivolumab as category 2A. And they have not mentioned anything about PD-L1 when the paper is out. The initial results are out since last 2.5 years.
Yeah.
Why have they not recognized 50 months versus 8 months? This would be category 1A of category 1.
So immuno trial interpretation and acceptance is different from every cancer. And you look at FDA, how it gives approvals. Now, in bladder cancer, FDA said, let's not differentiate. And they gave approval for everyone for Nivolumab as adjuvant, PD-L1 positive
IPT.
and negative. Now, the same thing you go with stomach cancers. In metastatic stomach, they said, the trial said, my primary endpoint was CPS more than 5. But they said, even if zero showed benefit, one showed benefit, they said, we will allow it for everyone. Now, if you go to different cancers, there's this controversy which starts off. If you go to EMA guidelines, now EMA clearly said in bladder, PD-L1 positive is where the benefit is. That's where we are approving it. And they actually said, show us the analysis for PD-L1 negative patients. There is a small analysis which has been done in the supplementary text. It's there, but it was not powered to do it. So they said that it crossed the interval if you look at it there, and EMA did not allow Nivolumab for PD-L1 negative patients in the adjuvant setting. So that's why we are
PD-L1 negative has not been given. I'm just putting the charger on my laptop, otherwise it'll die. But I would like to know your comments on the PD-L1 negative patients. Why have they not reported?
So there was a small analysis which was presented, And it did not, they put it this way, the PDL negative patients also saw some benefit, but it's not that big a benefit as much as what we saw for the positive patients.
Right. Next is future of ctDNA. We have 3 to 4 minutes. Your phone is wapas unmuted.
Right. Sorry. Yeah.
How future of ctDNA? Yesterday you were talking, when we were talking, you were talking about ctDNA and Tambola trial. So, is that how we are going to use immunotherapy? Because, bladder space is now exactly like lung space. CheckMate trial of just 3 doses of Nivolumab has been my favorite, and it is India specific, I feel. And then I start looking at Adjuvant 2 IOs and new Adjuvant 2 and perioperative 4 trials, and you get confused. So here, do you think that ctDNA based immunotherapy is going to be the future? Amit, your thought process about it.
I think, Amish, you said it exactly what we keep saying it again and again. It is exactly like lung. So with lung, we got the adjuvant data. We said adjuvant can benefit. Atezo is benefiting your PDL1 positive, Pembro is not. And then you got the new adjuvant, then the perioperative data. And all of us say perioperative is good, new adjuvant is good. And as you said, new adjuvant for India is perfectly fine. And now we have the same questions in bladder cancer. If we do adjuvant, do we do it for everyone or do we do it for PDL1 positive? One could always debate between this point. I lean more towards everyone because of those various variations. But with the neoadjuvant data, I would rather do neoadjuvant and offer it to everyone. And if I had PAT-CR, though the trial says continue, I would be tempted to say don't continue. Just like the 816 thought us in lung. But I think these are all clinical decisions which don't have too much trial backup. So using ctDNA is the future, and I absolutely believe that's the way we should be going forward. We learned this from the negative study when you looked at the IMvigor Atezo trial. 110 is negative, but you clearly saw in that if you had PDL1 positive patients, the ctDNA positive patients, they are showing benefit by adjuvant, and negative is not. Now, I like this Tambola study. They presented this ESMO. Small study, but clearly looking prospectively. Surgery, new adjuvant treatment, surgery, positive, ctDNA positive, ctDNA negative. Positive patients, they are the ones who are giving Atezo, and negative patients, they are just following them up. And clearly, those patients who are negative are hardly relapsing. All the new trials, if you look at the modern trial, which is now going on, it's a very interesting design, looking at new adjuvant, do ctDNA after surgery, positive, escalation with double immunos or single immuno, and negative, whether to give or not give, randomization. So I think the future is ctDNA in this setting. Probably it will help us choose better, provided we get a good ctDNA platform, easily accessible for our patients. And again, that debate will start, tumor-informed or tumor-uninformed, but I think ctDNA is the way for choosing adjuvant therapy.
So initially it was a clinical response, then it became a radiological response, then it became a PAT-CR, and now looks like PAT-CR is also going to be the thing of past. It looks like that, ctDNA. So Amit, my last question to you is, before the last question, I think the side effect profile, we all are very well versed. There was no new safety signal. Anything particularly about the side effect which you would like to say? Or it was the standard like any other?
It was very standard. It was very standard.
Perfect. So my last question to you is, you mentioned that this is a practice-changing paper. Okay. So now I would like to ask you, you would follow EMEA or FDA? EMEA says only PDL1, 52 months, and FDA says ITT, everyone. Your one-word answer, EMEA, PDL1 positive, or would you offer to PDL1 negative also?
I would offer FDA because the curves are separate, though we don't meet statistical significance. But I would say you keep hoping that some patients become immunoresponders and become long-term cure patients. So as of now, I still say FDA, but I think as further analysis of the OS will come, because this was just the first presentation of the OS, and I think as more analysis come, let's see what the answer comes out.
Let's see what the answer comes. I think I would request Sudeep Gupta sir to give one more meta-analysis like the way he has given of PARK inhibitor in ovary to see whether any of the HRD negative makes sense here, PDL1, whether it makes sense or not. My second question to you is, would you use immunotherapy or Nivolumab CheckMate 274 in upper urothelial cancer? If you see the forest plot chart, the pelvis and the ureter, the curve was too much leaning towards the right side of the forest plot chart.
Right. So upper ureters don't seem to be responding so well to immuno. We also saw this from our stage 4 patients. When you look at actually our javelin data, when you look at in the metastatic setting, even there, when you look at upper ureter tract, they're not doing as well as what the bladders are doing. So I think for upper tract, I still may not offer it, saying we have a clear POUT data, we could follow that. But I think we still need to wait for more time for using immuno for upper.
Still need to wait for. Perfect. Thank you so much, Amit. You have to stay on because you are also one of the panelists. Thank you so much for such crisp and nice answers. Over to Parikh sir to take this forward.
Thank you very much, Amish and Amit. That was a fine dissection of the final points for this study. And I think that the subsequent moderation and panel discussion is going to be even more intriguing. For the moderation, we have none other than Dr. Somashekhar. He is not only a dear friend, but he is a leading international stalwart that has, published immense amount of work, and he has led the Esther community into greater heights. They have developed and used artificial intelligence, and they are pioneers in many other ways as well. And it was a privilege for me to be part of one of his recent conferences. So without much ado, may I invite Dr. Somashekhar to start the moderation, and the panelists. You can see our Amit Rauthan, Arun Warrior, Nitin Yashas, Somashekhar, Ajay Bapna, Soumya Surat Panda, and Jayshankar. Over to you, Somashekhar. Go ahead.
Sir, thank you very much. First of all, it's an honor. I almost, I love this. I sometimes feel that we should just have one congress of only all the series you collected and just do 3 days, because this is the best critical evidence based than somebody just speaking from something else and then, putting a different perspective. Thank you very much. It's an honor, and I thoroughly enjoyed the interview. Thanks, Amit and Amish. So I welcome all my panelists. All of you are there. Without wasting time, so I will jump into this. Even though I have not made any questions or anything particular to anybody, please feel free to put your thought process, because everybody who was seen on the screen are great minds, great scientists, great clinicians. There is, the art of reading a paper is not reading the line, but reading in between the line, and reading it as if you are a patient and what is really beneficial, not just as a clinician, which is theoretical benefit without actually the meaningful benefit. And then there's a lot of knowledge in a different way. So I welcome everybody. Why we went to this particular paper. You all read the initial NEMJ paper, which was there, and now the detailed analysis of an updated analysis. There are some inherent thing which is very important to understand. Today, in urinary bladder cancer with muscle invasive disease, still organ preservation unfortunately has not come, which is very sad for a surgical oncologist, where in all solid tumor organ preservation has come. If there is one organ next to larynx which needs to be preserved, it is the urinary bladder. And in spite of the best treatment, neoadjuvant, adjuvant, chemo, immuno, markers, and so many, able to identify it in situ change, intravesical therapy, multiple options, fantastic radiation technique that has come. Level 1A organ preservation in muscle invasive is still not yet reached. So this is something which is very sad. In spite of the best RT, you will end up with an organ but non-functioning timbal bladder, which is not there. So organ preservation becomes a very important issue. So there is an important arm in any trial we saw. A good radical cystoprostatectomy, doesn't matter you do robotic, but still it is an organ ablative procedure. So why this came is, all of us know that if you survival after cystectomy without neoadjuvant chemo, we all know that as long as you have T1, which is close to 88, 89, the moment you go beyond T2 and you have a lamina propria and muscle invasion, look at the difference today that was published. It was a landmark paper published in European Journal of Urology 2012, which acts like a landmark for all medical oncologists and then a surgical oncologist practicing uro-onco. 64, and the moment you are node positive, you are at 31, which means almost 2 out of 3 patients you lose. So this is where the unmet needs came. Amit already spoke about it. Summary of 15 trials of multiple patients. But if you look back, how many patients really can take? Recent ESMO updated database and guideline, if you see, 50% only can tolerate neoadjuvant cisplatin. And the patient who takes neoadjuvant, 20% only end up with surgery. They come for surgery, whatever reason. Side effect, complication, not fit, they want to refuse. And then absolute difference of survival is 8%. And I'm going to show what is the pathological CR rate of all the summary. So this is one of the reasons that, neoadjuvant cisplatin. But it has to be given in this way, who are eligible, tolerable for cisplatin, otherwise you don't have. And I summarized all the trials which showed neoadjuvant, various trials, right from EVA-TC to recent Vesper. The maximum PCR that can run is usually in the range of 15 to 42. None of them are more than 42. So which means 50% or 60% don't do. That is where we have. We have now all these trials which we have available. Now I'm going to come back to CheckMate 272 recent updated data. What is the benefit that happens and where we are in particular in response to this particular, where the PD-L1 outcome actually changed everything for us? Because, the moment we have chemo, which I showed, the survival is at 8% absolute different and we jump to 16 numerical. Maybe the first question I will actually put to Arun Warrior. We have 3 trials. If by concept immuno helps, why is it that there is an inter difference between the 3 trials? Why IM Vigor is not same as CheckMate, and why the same thing is not in Ambassador? Why if you look back, all the 3 trials I enlisted the hazard ratio for DFS and OS. If you look back, why do you think that CheckMate 274 showed OS benefit, IM Vigor didn't show, even though it is a immuno, pretty much everything is same, only atizol is changed? What could be the reason?
So one of the things which I also reviewed this for that. So what they're telling is that in Vigor, the patient selection may be different, because generally what we experience around 13 months survival. In IM Vigor, the placebo group had survived for 16 months. And while if you look at the CheckMate, the survival was hardly 10 months. So there was a difference in the patient selection is what the comment is from the articles which I could understand. Ambassador is very recent one. Very recently it has come out, so I couldn't get any reasons for that.
We'll come to that. What I wanted to know is it different patient group alone, or you think atizo is not a great? Now you also know that atizo in HCC.
No, yeah, again in the same article,
it's not a good immuno, wrong selection of immuno.
Yeah, the statistical thing. So that this point also is debated in that article. So what they're telling is that it may not be much difference, because we know from other areas also that there is not much of a difference between the thing. That's what the scientific discussion goes on. So it is basically a statistical way, the trial design and the patient subset. So these 3 were highlighted. That's what I could get.
Okay, Dr. Ajay Bapna.
Yes.
Is it a wrong atizo, wrong different patient, or is it PD-L1 versus PD-1? Because the difference, the way the Nivo and Pembro and then atizo. Is this one of the reason which changed different patient, not a good or right atizo, or maybe the way they act PD-L1 versus PD-L1? Do you think anything more is there when we have one fantastic trial which is CheckMate 274, and there is another which is practically OS negative trial?
I think there is a problem with the design of the trial, which they have not used the same population, same assay, and the cells which they have targeted to check the immune response. So these are different in all these 3 trials. So they are not similar trials, but are very different trials. So the results are different.
Okay, so this is something which is, I would say that, people say it is a negative trial. But as Amit told, now that, we have Guardant Reveal, US FDA has approved in urinary bladder CA. And then even though Ambigor is negative, there is a group of patients where if you separate ctDNA positive after surgery versus negative, I know that this was not the primary analysis, so it's not fair to really compare because that was not the main aim, and down the line they looked at it. Significant survival benefit in those patients who continue to be ctDNA positive after surgery. So much so that, I put the curves here. I separated these two and then I put the curve. So if you look back, those who are ctDNA positive, the OS benefit, and those who continue to be ctDNA negative didn't derive a benefit. So much so that, the new trial, which is IMvigor 011, has been initiated. So my next question is, Nitin, so do you think it's not actually truly a negative trial in a different wrong population with a different type of PDN versus PDL1, different assay, yet probably there is a hidden message here? How would you interpret this?
Sir, I definitely think, as Dr. Amit also said, that going forward, ctDNA is going to make a difference. Looking at the curves that you showed, one of the reasons the IMvigor possibly could have failed was that almost 67% of them were ctDNA negative. And so possibly that's why the benefit was not being seen. But I think further studies which look at ctDNA in a phase 3 randomized, like we are looking at it in colon with regard to chemo, is going to give us more answer. Theoretically, in the back of our mind, we always think that PDL1 inhibitors are sometimes inferior to PD1 inhibitors based on just a theoretical aspect of how they work and how they engage T cells. But again, looking at the ctDNA data, I think there is more than that meets the eye.
Okay, just extrapolating this particular thing. So we already see a fantastic DFS with, the CheckMate 274. Do you think that if they had done something like this, imagine PDL1 more than 1%, then you look ctDNA, do you think it would have been like hell and heaven?
Yes, I do think that ctDNA would make a huge role. I don't think you would see a benefit if ctDNA was negative, even in the PDL1 population. And again, the one interesting aspect is that the Ambassador trial with pembrolizumab did not show the OS benefit, though it showed the DFS benefit. But again, study design with crossover and withdrawals possibly impacted it. And I think almost 15 to 20% in the Ambassador trial went on to receive another immuno in the second line setting. So I think cross-trial comparisons is confounding the matter, but one clear message is going forward, ctDNA would possibly be giving more guidance than PDL1.
And also Ambassador opened a new Pandora box. Here we say PDL1 positive, and suddenly there, it was okay to do with both. I just remember in one of those TNBC, new adjuvant, you don't need PDN, but the moment it is metastatic in TNBC, you need it. It's just surprising. So Ambassador opened that. So probably there is something in between. Okay, now I'll play the devil's advocate. I know that, everybody, this truck between the two curves, right? Truck between the two curves. Everybody is so happy. But I would just want to take a step back as a surgical oncologist, and I want to put a devil's advocate. Is CheckMate 27 really good, or they selected the right patient with the right thing, all the right ingredients to make a rasam? No, not one wrong. I will play the devil's advocates to this. I'll put this to Dr. Soumya Panda. I will put this way. We know current standard of treatment for patients to derive that 8% absolute survival benefit was to give a neoadjuvant cisplatin. Here is a trial which is a little bit underpowering. Only 39 to 43% received neoadjuvant chemo. So you can know that it's written there, cisplatin. More than 50% didn't even receive. So what are the use? You could have probably given everybody that you did not. Second most important point, if you stratify, I read the supplementary like what Amit told, and patients who received neoadjuvant cisplatin versus patients who didn't receive neoadjuvant cisplatin, they are N is equal to 308. You look back the forest plot, truly the patient who benefited in this group, we leave the PDL1, I'll come to that, are only the patient who truly received neoadjuvant cisplatin. The other one is so close, it is just a statistical play. So now we know that in this trial, Nivo needs a carrier of neoadjuvant cisplatin, yet 39 to 41% only took. What if you had taken 80% of neoadjuvant cisplatin and you had followed up with the current NCCN 2004 update? Do you think it would have benefited this? I will put this question to Dr. Jayachandran. I am really appalled. Here, there is a level 1 evidence of neoadjuvant cis. Only 45%, even actually, if you look back, 39 to 42 received, and yet the pronounced effect of adjuvant Nivo is only you in the group which received chemo. So there is something written, isn't it? So is there a different population, Dr. Jayachandran?
Dr. Somashekhar, this is Dr. Soumya Panda speaking.
Yeah, hi, please go. Sorry, Soumya, for you.
Yeah, so the thing is that, yes, definitely in this trial, if you look, then more people, we were expecting that more of the new adjuvant should be there as per the trial eligibility criteria. And however, the prior new adjuvant was a bit less compared to what we do in the real world practice. And first thing is that. And second thing is that regarding the interpretation of the result, that whether neoadjuvant chemotherapy population versus patients who were adjuvant. So in that subset, I think that this is a forest plot, and the primary endpoint has to look at the intent to treat, and overall the intent to treat looks positive. So getting into a forest plot and interpreting and bifurcating is hypothesis anything, but concluding that neoadjuvant chemotherapy versus adjuvant will be a bit of a stretch.
Okay, Amit, I tried to read
Let me answer your questions, Dr. Jayachandran here.
Yeah,
so I understand your points. The amount of patients who received the neoadjuvant cisplatin is less in this group, but your theory of that, what you say that the patients, if more number have received, if the forest plot has shown the other way around, if the patients without neoadjuvant cisplatin had shown more benefit than the patients show with cisplatin, then your theory may work. So then your theory may say that if more number of patients really in the real world are getting more cisplatin, then I would say that your hypothesis that the trial had included less number of cisplatin patients. So, but if you look at the patients who received cisplatin therapy had a better hazards than the patient who didn't receive the cisplatin therapy. In that case, if the more number of patients were included, the hazard may be better than that of what we expect to be lower. But as you said, 43 is a lesser number of patients. That is based on the trial design as well. So all these things are basically trial design and what to do with PD-L1 testing, all these things.
Correct. Before I go to Amish, I will just tell Dr. Amit. Amit, did you really read in the supplement neoadjuvant cisplatin, then adjuvant, Nivo, neoadjuvant no cisplatin or adjuvant chemo? Do you have the exact data and the DFS and OS in that? Did you come across it anywhere? I tried to read too much about this, Amit, and then I go to Amish.
No, Som, you're fully correct in this. You're absolutely correct. So what the clear benefit is coming for only those patients who receive cisplatin, and those patients who did not get chemo, then the benefit is really not significant at all. And that's the whole thought which comes out in bladder cancer is by giving cisplatin, are we opening new antigens, increasing the way the immunotherapy will work. And we have seen that even in the metastatic setting, where if you didn't give cisplatin, addition of immuno did not work. But when you added immuno to cisplatin, you got a better response. Even in the neoadjuvant studies, now it is always being thought there should be some chemo and cisplatin should be the ideal one to get that response. But there is so a lot of people, if you look at a lot of commentaries, they are saying if you are offering adjuvant patients, you should only offer it to those who got neoadjuvant cisplatin, who are bladder cancers, and who are PD-L1 positive. And that is a small segment of patients. These are the ones who should be offered Nivolumab. The others may not benefit so much at all. But again, as it comes out in clinical trials, a lot of exploratory analysis, a lot of ad hoc analysis. So it becomes a little difficult, but the point you're making is absolutely correct.
Amish, for you.
So, Dr. Somashekhar, you are absolutely right. I tried to dissect this forest plot great detail, tried to read also. I was baffled by this thing, but we have to also, when I looked at the PD-L1 positive and PD-L1 negative, the graphs are so separating that all these, everything else, somewhere in my mind starts going down. And second thing is, which we discussed this many a times in OBTO, is that forest plot is not the sacrosanct proof about the data and practice changing. It is more of a hypothesis generating for future trials, or look at the retrospective data of the trials and then come out with the thing. So I think based on forest plot, our practice does not change. As you know, Amit very clearly mentioned, he would offer Nivolumab to all ITT patients because that's how the trial is generated and that's how the FDA has given the approval. The FDA also have gone through this forest plot chart, right? And they have not mentioned that only those who have received cisplatin should receive Nivolumab. So I think that is the point I wanted to make.
So I fully agree with you. So before I go to Arun and Ajay, I think both are there. There are three issues. Maybe I think Arun and Ajay both can take. Number one, it has been already repeatedly pointed out, we don't have a right immuno for upper urinary tract. The CheckMate predominantly helped for urothelial CA from bladder, but if you look back the ambassador with Pembro, it has a large amount of lower ureter as well as lower tract, and it's promising, about 2023 still benefited in that. So this is something which is in CheckMate, that it's a criticism, but it's just that, it's not that nobody want to include, it's how the cases come during that time. And PDL1 negative and positive has been there. So these are the three groups: prior chemo, PDL1 positive versus negative, upper tract versus lower tract. So Arun and Ajay, can you please take it crisply?
I think it has been clearly mentioned that the upper urinary tract transitional cell carcinoma is not responding to the immunotherapy. So it is only for the muscle invasive bladder cancers, which are high risk post-operatively, and more so in the PDL1 positive patients. And because of the heterogeneity that, only half of the patient receive neoadjuvant chemotherapy. So the European Association of Urologists have given this trial, evidence very weak evidence in comparison to the American Association of Urologists, which have given it as a higher level of evidence in comparison to the evidence generated by European Association of Urologists. They will still not consider this.
Absolutely. Arun, Amit in his interview briefly touched this. I dissected a bit because that was my job. I had all the time to dissect. So I have this value exactly, PDL1. He was telling CI, confident interval HR, but I put it here. So PDL1 more than 1, look at the HR, 0.56, confident of 0.4, and PDL less than 1, 0.82, confident of more than 1. So how can you just give your opinion on this?
Yeah, actually, why I raised my hand was to draw attention to the pembrolizumab thing, because when you look into the ambassador, because pembro is there in the upfront metastatic setting, we are giving it. That is a preferred one. So I was trying to find out what they tell is that the 3-year OS is actually 60, just 1% difference is there, because by the time OS came, most of the patients could cross out to nivolumab. So that is the reason they tell. And if you look into the subset of ambassador also, there again you see the same thing, that the PDL1 positive, the DF is almost double. PDL1 negative, it is almost the PDL1 negative also, it is only 17 versus 9 months. So I think both the trials, actually it's interesting, the CheckMate and Ambassador are telling the same thing actually, that the PDL1 is important. And one other thing is that in Ambassador again 67% neoadjuvant chemo. So that may be the reason many of them were MRD ctDNA negativity was there, because but then we don't know why, even with a lesser neoadjuvant, more people were positive in the other group. So that also has got a role. The neoadjuvant has got a role, definitely. That is why ctDNA events may be less. And unfortunately, because of the nivolumab, that is why Ambassador could not get the survival advantage.
But pembro in metastatic setting is in combination with the.
Understood. Yeah, it's an effective drug. That's why I wanted to understand why it is not getting approval in adjuvant.
Yeah, what he told.
Only in combination with the ADCs.
Understood.
Okay, I will little bit switch gear since the today's moderation and discussion is CheckMate 272. We will further deep dive down, into this particular area. So as you told, PDL1 by DACO, as Amit told, nobody does this, and it's so confusing. You use a PDL1 using a CPS score, and then you also use Bayes percent. So in view of this particular thing, because Ambassador, I will tell you the final recent analysis and conclusion and a lot of editorial written on what should be the right way. Ambassador versus this and the Niagara. I will come back to that. This is what was actually written there, that in Checkmate 274, various recent editorials. We know there is a very good one. If you leave the PDL1 and other group, lack of overall survival benefit, even though huge DFS was there, we'll wait for that. Little bit higher adverse event in this compared to other trials. And PDL1 negative patient did predominantly benefit. And imbalance in the baseline characteristic and quality of life consideration is not considered. We can actually go back. Upper urinary tract patients were not optimally here, there, because we didn't have. And long-term benefits will be waiting. Most important criticism, Amit, if you follow the Checkmate 272, what next? Because you need a sequencing. This is where the Niagara Ambassador sort of little bit, because there is a second, third plan. So how do you really plan the subsequent therapy after a Checkmate 274 trial down the line?
So if we have given 274 and patients progress, again, we will come down to the same thing of when they have progressed post-immuno. Did it happen within the first 6 months, first year, or after a year? Rechallenge of immuno may be there, definitely for some group of patients if they are late relapses. Chemo may also be reintroduced if there are late relapses, but I think EV will have a very dominant space in this place. And it is because the EV data is getting so good in every setting. I think EV will become a dominant treatment post-progression of adjuvant. But again, we need that access of EV in India, which I hope this year we are going to get, and that's why that will change our thoughts about next line of therapy.
But Amit, rechallenging is with another IO is a little bit difficult.
So if it happens after, so this is only 1 year of Nivo. Now, if patients progress after maybe 1 year again of 1 year of observation, I think we can definitely rechallenge IO. We use IOs for 2 years with Pembro directly with no consideration at all. We use much longer indefinitely for metastatic disease. So I don't think that's a problem. It's just that if it progresses within 2-3 months, I clearly think IO is not going to work. And that's where we'll start debating. Now, the problem will become, how are we going to give EV? Is it going to be a single agent or is it going to be an EV Pembro for metastatic first line? Absolutely. And that may matter depending on when it has relapsed after IO usage.
Absolutely.
So again, I want to emphasize one more point, that there is a new generation of patients who are ready to accept invasive disease-free survival or disease-free survival in lieu of overall survival, that it's okay for us if you can delay our recurrences. And it is the group which was included in Checkmate 274 was a very difficult, patients. So all the recurrences occur within the 3 years. If they remain disease-free for, say, first 2 years, 2.5 or 3 years, it's okay for some of the patients, or maybe most of the patients. So the patients are started accepting this marker, this endpoint.
Absolutely. Today it was such surprising. I was going to moderate this today, and I had a patient. Many patients don't want radical cystectomy. It doesn't matter. We do an intracorporeal and, you avoid a stoma. Still, nobody likes that. I know today we don't have a level 1A path. Suppose a patient has taken neoadjuvant chemo with or without immuno, say that Niagara type. If a patient achieves clinic imaging, cystoscopy, biopsy, PCR, what would be the way best for those patients who refuse any form of surgery? Today, you think based on this, what would be the best option for them to continue, even in muscle invasive? So I would request Dr. Panda and then Jai Chandran to give their view. Chris, one line, what would they do? They have taken neoadjuvant, they refuse for surgery. Now, what would you take them through the path?
I would, if the patient refuses surgery as on date, I would advise them to go to the radiotherapy followed by adjuvant immunotherapy. This is what I would.
Which immuno would you do? Nivo, Pembro?
That depends on the patient. If the patient has taken a Niagara, then I would go with the Nivolumab continuation. If the patient has taken no chemo, no immunotherapy, then I would prefer to go with Nivolumab rather than with the data available.
Okay.
So Dr. Somya, so my point will be that if the patient has been exposed to gemcitabine and cisplatin, and then patient is unwilling for the cystectomy, then we will go to the CTRT, and then probably we'll have to keep on, means at least I will keep on follow up, because this is a data free zone. we don't have a data to support any Nivolumab in this particular, or say Ambassador, or say other trials. Probably give CTRT and then keep on follow.
Okay.
So,
It's
so
also important to know patient who take radiation. Yes, you would have in urinary bladder, functioning bladder is extremely important. Radiation is something which would take away a little bit of quality of life and functioning, even though DFS OS is achieved. Nitin, you wanted to add something?
yeah, I again, in a data-free zone, I'm just thinking, because of the ease of access which is there, because sometimes we have come across 75, 76-year-old patients who say upfront itself that, look, I'm not looking for a cystectomy. So would we use Nivo plus Gemcis, go for radiation and then continue Nivolumab? Whether that's sort of a pragmatic approach to use, because we have the Nivo Gemcis data in the metastatic unresectable disease, and we know the response rates. And again, as we have all discussed, usage of IO plus cisplatin gives us good response. And we all know that the radiation and the abscopal effect is there. So for patients who are not willing for cystectomy, whether, again, completely data-free zone, going with Nivo Gemcis followed by radiation and Nivolumab continuation may be one approach to
If
take.
a patient is very clear, we have some patients who are very clear what they want, what they never will.
And another very, very interesting thing about this OBTO right now is quite a few of us from Karnataka, and we all know the sort of hot news in Karnataka about celebrity undergoing bladder cancer treatment recently.
But anyway, he opted for radical prostatectomy and neobladder, so fine. Okay, second thing is, Amit touched upon it, but I will again put it to Dr. Ajay Bapna.
Yes.
PDL1 1% versus TPS score.
So I think it is if given choice to me, I'll prefer a score which takes into account both immune cell and the tumor cell.
Okay, fantastic. Because we know in CheckMate it was PDL1,
Yeah,
and then
so I don't want to leave any
Ambassador with
opportunity.
MST
So I
platform,
don't,
which
yeah, I don't want to leave any opportunity, and it's a good idea to take into account an assay which takes in consideration both immune and the tumor cells.
okay. Now we'll open further Pandora box. Everywhere in the immuno, colorectal, if you have DMMR, neoadjuvant, why you want to operate and give anything else? Everywhere we have jumped, even in now lung, stage 3B, so, eligible patients, so they are neoadjuvant. So looking at checkpoint inhibitors in neoadjuvant with all these studies, all the studies which are going on, which are coming up, and one reported already presented. So of all the thing I've enlisted, we will now analyze in this era of this particular, how do we really look at our keynote CheckMate trial. So we know that we have these phase 3 trials in cisplatin eligible patient, keynote 866, Niagara, EV, what Amit told, and also Energize. So in this era, at least we'll jump to the trial which has been actually presented, awaiting the full publication. Niagara. This is extremely attractive. Imagine if a patient has undergone a surgery, it is very important that at the end of 4 to 5 weeks, they should take the adjuvant, right? That is one of the most important criteria in most of them. Performance status of the patients actually drops down after a major surgery. And why you want to operate and then do it? So now where do you fit Niagara in vis-a-vis in this context now that we have two? Why give later? Why not give before? So, Arun, you can take this.
I think if we can use a drug in neoadjuvant, that's the best time to do, because we know whether it is going to be effective or not. And then definitely in all the cancers we are seeing that there will be improved response will be there. But then they're not selected based on PDL1. If the selection was based on that, it would have been better, because now we understand that PDL1 is such a strong marker in urothelial carcinoma. So that's what I take.
Yeah, because when I really went between the lines and said very close to 30 to 40% PCR already in Niagara. I read a statement in the ASCO site 2 days back. In this era, a patient who achieves PCR by neoadjuvant immuno has no role of any immuno.
Yeah.
I don't know. You all read that. I put it today. If somebody has achieved a PCR in all solid tumors by neoadjuvant immuno with or without chemo, to justify an adjuvant immuno today is tough. So almost close to 34-35% with Niagara already PCR. Amit, how do you interpret this? CheckMate 272, I'll put it neoadjuvant cisplatin, 45% take it. Adjuvant 1 year Nivo, or Niagara, where 4, Gemcis Durva, very high PCR, even though in the trial 8 adjuvant Durva was given. So in view of these two, how do you fit it now? Niagara versus CheckMate. Tomorrow you have a patient coming, muscle invasive. Which path you want to take? I know cross-trial comparison is not fair, but you can't stop preventing this. So what do you think?
I think we are learning from almost all the cancers there that probably theoretically doing neoadjuvant is better by you adding immuno to chemo because you have the tumor in place. So the way your neoantigens come out and the way your T cells get primed and the way the immune response comes, it's probably theoretically better to do it upfront. So I think neoadjuvant versus adjuvant, I favor neoadjuvant. Now the question is, neoadjuvant, what disappointed me with Niagara was you went up from 27% in the comparator arm to 37%, that also with a reanalysis of the PCR rate. You had to reanalyze it because it was 24%, and then they had some more patients, they reanalyzed everything, and they went from 27 to 37%, which to me is pretty disappointing. We already had touched, Vesper had given us a 42% patch CR with neoadjuvant chemo alone. And it always kept thinking, probably when you add immunochemo, you should get a much higher patch CR. So that was a little disappointing for me in Niagara. But again, you have to compare it, and there are two clear comparator arms with big numbers. So clearly 10% more patch CR we are getting in the Niagara. So I would probably think that's the way forward for us. What is difficult to interpret and answer is the question you clearly said, should we give adjuvant immuno? How much is that Durva which is giving post helping those patients, especially that 38%, that 37% who got patch CR, whether they're really benefiting or not benefiting? And that's the question we keep asking ourselves, even from the keynote study for Pembro in triple negative breast cancer. We keep saying we give the post, does it help or not help? We don't know that. So is it really benefiting or not? But I don't think we'll be able to answer it without doing a proper clinical trial.
See, as a surgeon, when I look at forward, in an ideal situation, what you say, people who are able to take neoadjuvant then follow. But if you look back in the CheckMate, 45% took. I don't think it is because they have not offered it. Everybody may not be cisplatin eligible. And if you look back all those 13 to 18 neoadjuvant cisplatin, the maximum completion and accountability is 50-56. Now, if you look back, CheckMate versus Niagara has more people who took neoadjuvant, maybe because it is not the classical but a gem. So maybe there is a trial which is little more quality of life, less toxicity, more compliance. So I know that in an ideal world you take the best. It's like FOLFIRINOX you take, and how many can take FOLFOX? Amish.
Yes, sir. So last point what you brought out is absolutely correct. But before that, I think to compare Niagara with CheckMate 274 probably is not correct.
Absolutely.
Because in Niagara, 100% of patients received chemotherapy. While in CheckMate 274, 60% did not receive. Exactly. So I think it is more of an apple to orange. That is what I wanted to say. And the second point, the point you brought out, I think CheckMate 274, we should answer that question. Patients who are not eligible for cisplatin, should we offer them Nivolumab after cystectomy? I think that probably is one of the huge population. As you rightly said, hardly half of our patients are cisplatin eligible and 30% are not even carboplatin eligible.
Absolutely. So, now, so we have Niagara as Durva, then we have Ambassador Pembro, then we have CheckMate 274 new. Atiso will keep it away because poor chap that is running little back, unless you put a ctDNA, it's not coming up straight up. So tomorrow, by the philosophy of the whole discussion we have, with your experience, what do you think would be the way forward? Which immuno should be in the future trial, or it doesn't matter? Soumya and first for you, Panda.
So the Niagara trial design is very different from the Nivolumab and Pembrolizumab trials. So in the Niagara trial, there was a lot many T2 N0s and lot many non-negative patients were there. And second thing is that Niagara had a primary endpoint of PCR. So right now in bladder cancer, we don't know that PCR is a surrogate for a survival or not. So that itself making a primary endpoint of PCR and then ultimately getting the result that is also not significant. So your primary endpoint of PCR was not significant in the Niagara trial. So as of now, and again they had 59 while evaluating the slides, they had 59 slides missing. So the PCR reports were later given up. So with that also, it was not statistically significant. So for me, I don't means I'm not much in favor of the Niagara. Probably Nivolumab, the trial CheckMate 275, that looks better to me.
So for you, way forward in TCC, bladder muscle invasive, Durva, Nivo, Pembro, Atizo doesn't matter, or what do you?
No, it is mostly the data looks better for the Nivo PD-L1 positive subset. So that is very clear that somebody who is PD-L1 positive and the adjuvant Nivo looks much better comparing all the three trials. Though comparison not correct.
Thank you, Jai Chandra.
Yeah. Moving forward, what I would think after Amish rightly pointed to the point, all the patients in the comparator arm received chemotherapy in the Niagara study. So we should not compare these two trials, Niagara and CheckMate 274. So for patients who are fit enough for gemcitabine cisplatin-based chemotherapy, I would think about giving them durvalumab with gemcis as a first line as a neoadjuvant therapy, and then go for surgery. And patients who are not eligible for any form of chemotherapy, I would think about going for surgery and then give them nivolumab as an adjuvant therapy. This is what I would think about with the available data, because these two trials cannot be compared. This is why there was difference. Then median EFS was not reached 46 months as of now with the Niagara study, whereas its median EFS
No
of 10 months
adequate
with
events also, yeah.
Yeah, median AFS was only 10 months because a huge number of patients did not receive chemotherapy in the Niagara study. So we cannot compare these two studies. So for patients who are eligible for cisplatin, I would think about doing durvalumab with cisplatin gemcis, and patients who are not eligible for any neoadjuvant chemotherapy, I would advise surgery for nivolumab as a adjuvant therapy.
Okay, Nitin, Amit, not too much explanation. One line. So
yeah, so I think there was just one question which Dr. Sahu had asked in the chat, and that was with regard to is PAT-CR important? Actually, there are meta-analysis which have shown that PAT-CR leads to better survival outcomes and also a change in the tumor microenvironment with a decrease in the immune regulatory cell, the Tregs and all. So I think that PAT-CR does make an important difference, and we have quite a few meta-analysis and again the biological reason. Going forward, I would always look at a PD-1 inhibitor. We have data of Nivo Gemcis in the metastatic setting. I think we should I hope they run a trial where they do Nivo Gemcis followed by Nivo continuation, or like the lung trial, Nivo Gemcis and no more further Nivo if there is PAT-CR.
Amit?
So the advantage of Niagara is when we talk about Niagara to our patients in clinics, we clearly can say we are getting this much DFS benefit and we are getting overall survival benefit. And you have already hit OS benefit. Now, when you have OS benefit in the whole population, there's no reason to deny neoadjuvant immunochemo to patients in bladder cancer. So I think clearly with OS benefit there, we clearly can say that is standard of care. The disappointment always is even with getting good responses, are we still able to preserve bladders? And that's where the whole issue comes, which you talked about. We're not able to preserve bladders, and that becomes a problem. And secondly, I think we may beat all this when we get the EV304 data of using EV Pembro in neoadjuvant settings. And that's where all the thought is going in. Probably there you'll hit more higher PAT-CRs and better events, better survivals may come out. But looking forward to these data sets.
Absolutely. I read a lot of comment reviews written on both the trial comparison. I read because between night 12 to morning 3 I read most of them, so I little bit assimilated between the both comparison. If you see, Nivo gave a fantastic DFS, especially in PDL1. Statistical significance of Durvo is little bit going well. Safety profile, not much to pick up, but still previous study based on that shows a better safety profile consistent with Durva here for us. Both trials are good, looked at very, very, very well. But if you read all the leading critics who have written addendum to that, the Niagara trial looks more promising. That would help us to build up the right right neoadjuvant, right adjuvant, and probably eventually everything would move in neoadjuvant. We may not have hit the right neoadjuvant regimen to follow up, but when you compare both of them, the benefit and then a toxicity profile easy to complete, and then giving this, probably this looks. And we all know that the whole reshaping happens how the perioperative and the neoadjuvant actually turn out. And that is where all the modern schema is situated where we would actually go ahead and then we know. I would request all my panelists to add anything which they want to do in the last 5 minutes, please. I saw some hands going up.
So there is a similar trial in head and neck also. Recently, it was, I think, pre-proof analysis of post-op Nivo. The patients who have received neoadjuvant chemotherapy and post-op with high-risk group, they only gave maintenance Nivolumab. So that also speak a volume about the maintenance IO in head and neck high-risk patient post-op. The trial is post-op Nivo.
Correct. But the way forward would be a neoadjuvant. Unless we move something best into neoadjuvant, we can never achieve organ preservation. This is one solid tumor which is eluded, where maximum organ preservation next. Now in larynx, rarely anybody do oncological excision, and rectum, now 75% of sphincter preserving surgery, and then now no surgery after TNT. This is one which is eluding us, and I think unless we move the best thing to neoadjuvant, we don't achieve that. If you don't try, this is not possible. And everything adjuvant is after organ ablation, which has changed the quality of life. It was a fantastic discussion. Very honored to actually preside over a moderation, just not being a medical oncologist with the elite medical oncologists of the country and international. Thanks to Amish and Purvish sir for entrusting me this. I hope I did a justice to this. I read a lot of things in between lines, and I am not biased because I'm not a medical oncologist. I don't give chemo, I don't give immuno, so I have no bias. So I'm like a impartial patient advocacy sitting on the back commenting on that. Thank you very much. Over to Purvish sir and Amish.
Thank you, Dr. Somashekhar.
Thank you very much.
Really very interesting.
Yeah, Ajay, you are absolutely right.
Yes.
And as I was looking through all the discussions and all the answers that Amit gave and all the finer points that Somashekhar brought out, the first thought that came to my mind is that if I was an exam going student and I wanted a gold medal, this is the sort of discussion, this is the sort of insight, and this is the sort of comparison that I would want. So absolutely fantastic job by all the panelists, by Somashekhar, by Amit. And of course, Amish was the one to push the needle and stick the needle in to provoke some interesting discussion. So I thank everybody. And
Thank you, sir.
I hand over to Amish to give his last comments.
Thank you, sir. Dr. Somashekhar. In fact, Dr. Parikh and myself, when we were thinking about you inviting you for moderation, we were thinking we should invite you as a medical oncologist or as a surgical oncologist, because I think you know both the subjects very well. And the key lies in that 12 to 3 a.m., which I'll remember reading about it. But I completely agree with Parikh, sir. We try to thrive more and more quality in OBTO. This set of interviewee, moderator, and panelist was very, very fabulous, very well read. I learned much, much more. And I think Tarini also was here. Tarini would agree. He's integral part of OBTO since inception. I think this was wonderful. Dr. Somashekhar, thank you so much. Dr. Amit, thank you so much. And all the panelists, I will remember this OBTO for a long time to come. Thank you so much.
Thank you,
we
Amish.
see you every second Tuesday of the month. We have OBTO. And Parikh sir and I sincerely request all of you to please invite all your students. If there is anything which we can do at our part to make them part of OBTO, please let us know, and we would love to do that.
We should do one conference of 3 days only on this, all the things you got, because nobody can give this knowledge. Here it is pure science, nothing else other than that, by best of the mind and debating with each other. This will be the best conference rather than best of ASCO, best of ESMO, best of anything, sir. You should really think of just take this 100 and run it for 3. It will be like the fantastic thing. All top medical onco-surgical radiation will be student. They learn more than anybody else.
I think Dr. Parikh did it once in some of the meeting. सर आपने कुछ
Yeah.
किया था मेरे ख्याल से
Yeah,
OBTO को लेकर.
we took the top 3 discussion that
Yeah.
we had and put
Yes,
a summary in one of the conferences. But what Somashekhar is saying is that we should make best of OBTO as a standalone meeting.
Yes.
And that is a wonderful suggestion.
Yeah, absolutely. And I think in that best of Dr. Somashekhar was there in that when we selected the best
I was there.
articles.
I was in Braca and Parp.
Right. Absolutely.
Thank you.
Sir, we can close with your permission.
Okay. Thank you very much.
Thank you,
And
everyone.
good night. Good night, everybody.
Good
Bye-bye.
night. Good night.